This is Market Pathways, your premium guide to global medical device regulation, reimbursement, and policy. Become a part of the global medtech community at mystrategist.com.
Welcome to another edition of the Market Pathways podcast. I'm Steve Levin, Editor-in-Chief of Market Pathways, and today's discussion can be filed under the category of needing more acronyms in the medical device industry. Today's podcast will focus on the current debate surrounding TCET, TCET, which stands for Transitional Coverage for Emerging Technologies. And for those of you who have been following this debate, you'll know that TCET is the new replacement for MCIT, Medicare Coverage of Innovation Technologies, which was repealed early in the Biden administration, and now the debate is on what will replace MCIT, and that's how we got to TCET. So having gone through that alphabet soup, today's discussion is an interview with Josh Makower. Josh is a familiar face to those of you who listen to the podcast or read Market Pathways. Josh is the director of the Stanford Biodesign program, which he also co-founded, and he helped launch the new policy module as part of the Biodesign program, which has issued a couple of reports. And today we're going to be talking about the most recent report that came out of Stanford Biodesign, which basically showed that reimbursement of breakthrough devices continues to lag behind the level of FDA approval, with the median time for breakthrough devices to achieve even the initial level of reimbursement heading to upwards of 6 years. And the reason why this report will hopefully prove to be very valuable for the industry is that Stanford has issued previous reports, with Josh Makower spearheading those efforts, that have resulted in significant regulatory change taking place at FDA. And the hope now, as this debate turns to reimbursement, is that similar change can take place at CMS. And just to provide additional background for those who may be new to this discussion about TCET, rather than establishing a new coverage pathway in its TCET plan that was issued in June, CMS in that proposal stayed well within the bounds of the current national coverage determination and coverage with evidence development framework. And just to kind of give you a short synopsis of that proposal, the agency proposed to front load its NCD application process for select FDA breakthrough devices to accelerate data review and generate fit-for-purpose evidence development prior to FDA authorization, with the goal of issuing a final coverage policy within 6 months of regulatory approval. So that's the proposal from CMS. And if you want to read more about that, I'd encourage you to look at the article that we did in the July-August issue of Market Pathways, which goes into that in much greater depth. But today's discussion will focus on the findings of the Stanford report, and again, with the hope that this plays a role in highlighting the problem and informing people as to what changes might be necessary in the CMS process as we go forward. So we hope you enjoy this discussion. So it's our pleasure to welcome Josh Makower back to the Market Pathways podcast. Josh, great to have you back again.
Thanks.
And this is getting to be a habit, And I think it's great what you have really pioneered, going back to the 2010 report and then your most recent report in 2022 on, I'm just going to call it MSIT, for lack of a better label, and then the current report, which we'll talk about in depth today. But for people who maybe have missed past conversations, let's start with a little bit of a background, and that is, what led you to embark on your report in 2010, which was titled FDA Impact on Medical Technology Innovation. And you're too humble to say this, so I can say it for you, which is, it's fair to say that, and to set the timing, that was really at the beginning of Jeff Shuren's tenure at FDA, at CDRH. And it was at a time when regulatory issues were really paramount for medtech companies, particularly small to mid-sized entities. And FDA was just on the cusp of starting to embark on the changes that they have since implemented to really improve that whole process. And what I was referring to when I said you're too humble to say this is that I think without a doubt, the report that you undertook in 2010, and you did it with a lot of help from groups like MDMA and many companies in the industry and investors as well, really sparked working with the agency to embark on a lot of the changes that have taken place. But it's not obvious that this would have been an area that you, as an entrepreneur, and again, I should point out, Josh wears a number of hats in addition to directing the Stanford Biodesign program, which he co-founded and then took over upon Paul Yock's retirement. Josh also has his incubator ExploreMed and is a partner at NEA. So it's not obvious that delving into the realm of data in medtech would necessarily be an obvious choice for you. So talk a little bit about how you got started, and then a little bit on the 2010 report, and then we'll kind of go into the report from last year.
Thanks, Steve. Happy to do that, and thanks for inviting me to chat here. First, just to frame this, it gets called my report. It absolutely is always a team that puts these together, and as you pointed out, always a team that then subsequently helps make change happen. I mean, we had a small team in that 2010 report. That was Lyndon and Abed Mir, who I work with, but had lots and lots of others from multiple groups helping to contribute to the foundation of that survey, which included FDA as well as NVC, MDMA, AdvaMed, and others, and many partners on the innovator side, from the Foundry and other organizations. And then even today, these latest two articles that we produced out of Biodesign are the collective work of multiple graduate students, faculty, lots of input from our collective or advisors who give us good input. And so it's really important to acknowledge all of their contributions, because I might be an instigator in this process, but it's like, this is a big group of people. In anything that you do, you have to build coalitions and teams, and these teams are working hard and they've done an amazing job. And their names are recognized on the paper, many of them in the acknowledgments as well. Right. So I just want to mention that.
Absolutely. It has gotten shorthanded to be the Makower report, but right. Again, we always acknowledge that there's a group there.
A much bigger group. So what I would say is that back in that time frame, around 2008 timeframe, we were really suffering from what was the perfect storm of issues. The financial crisis. We were looking at banks failing, which we hadn't seen in a long, long time in the United States. We were looking at, FDA with new leadership now, totally changing the way they were communicating with, applicants, and it was becoming very frustrating and difficult. And they were getting missed messages, and they, sort of made a behavior and management change without an actual legislative change. It just sort of the mindset changed at FDA, and it became very opaque and difficult to understand what they wanted, and I think they kept on changing what they wanted, quite honestly, at that time. Now, in that wave of new management, obviously Jeff also started with Josh Sharfstein, and then we had new leadership at HHS, and they all had I would say there was a little bit of an incoming bias that, we need to keep these in companies at the door. We should really revisit whether 510Ks are worth it, and maybe we should just do everything as a PMA, and everything needs a clinical study regardless of the significance of the risk associated with it. A new needle stopper might require something like that. So it's sort of really aggressive changes that were sort of in the offing, and it was very, very scary for innovators like myself and others.
And can I also point out one thing, because I think it's important for people to understand, although they see you now at Stanford, and that's why I wanted to point out the other hats that you wear. I think it's also important for people to understand that you walk the walk. You just didn't talk the talk, in that you went through this experience with your own companies. And I want to point to Acclarent, for example. I don't know how much you want to allude to that, but this is born out of what you had to fight those battles, not just you looking at how other companies are going through.
Oh, absolutely. And I would say Neotrack probably even more, because Acclarent was already through the regulatory process. They were facing huge, interesting challenges on the reimbursement side. But the regulatory process was actually relatively straightforward, at least for the first set of products. But no, yes, I was experiencing the same thing across all my companies, MoxyMed and Vibrant and Neotract at the time were seeing this, and it was very, very challenging. But honestly, all my colleagues, all of our colleagues were experiencing this. And I had this opportunity when we sold Acclarent, sort of felt like, a rare opportunity in my life to step back and go, okay, I've been lucky. We had a good win in terms of an exit financially, but then I look around and the environment was very depressing and very bad around me, and just felt like that's an opportunity to pivot, and instead of sort of taking a success lap, use those speaking opportunities to advocate for change. And support my colleagues who were not as fortunate yet. I think some of the changes that we made have helped many become more successful, but it was a tough time, and I was really worried about the future of patient care and the advancement of innovation, which I've dedicated my life to personally, professionally, and also in the creation with Paul Yacht for creating Biodesign in the first place. So I really thought the whole institution of innovation, medical technology, was being threatened by these changes, and that it required action. So that sort of put me forward in the game to understand, how do we make change? And just to sort of complete the answer to your question, the way data got linked into that was a very specific meeting that Mark Deem and I and Mark Leahy had with
Mark, I just want to identify for people who don't know Mark Deem of the Foundry, and obviously Mark Leahy with MDMA.
Had with Anna Eshu, and there may have been others there too, but I just remember us going, and Anna was very, very clear and taught me something about how it is to be on the other side and be a policymaker in Congress and be completely barraged by opinions of various people, people who have good reason for their opinions, but very diverging opinions, and yet not bringing facts. And she basically, I wouldn't say threw us out of the office, but she was quite stern in her comments and saying, I just completed a meeting with another group that completely disagrees with everything you're saying. And now you're telling me the other thing. And I just hearing opinion after opinion, stop coming in here and whining and bring me some data. Bring me some data, and then we'll have a conversation about it. But until then, I don't want to hear the whining anymore. Go back, get me the data, and then I'm happy to engage and talk about what we might do for this industry, for these patients, et cetera. Tell me what I need to do. And so that was really, really super helpful. And I felt that she was being sincere and in that request. And so that's what got us on to work with FDA and other stakeholders to put together a survey that we would deploy, which ultimately resulted in some pretty shocking information about how the FDA's sort of current modus operandi was impacting innovation, and also the cost of innovation and the threats to innovation, in the United States versus globally. And I think all those insights were combined into that report that we put together rather quickly, but was based on some really hard work, collecting some very, very sensitive information from multiple stakeholders. But it was very eye-opening when we finally did.
Do you want to highlight a couple of the key takeaways from the report again for people? It's been 13 years, so
yeah.
There are people who may not be as familiar with that.
Yeah, and a lot of this is dated. A lot of this, honestly, to Jeff Shuren's and FDA overalls, certainly on the device side, I mean, the transformation has been amazing. And, so I want to say that this is all historical concerns that in a large part have been addressed. There was an issue with ancient FDA processes in terms of transparency, predictability, reasonableness with respect to risk benefit, and a framework around which that they would evaluate applicants and applications that would be somewhat within a range of expected timelines and behaviors. And so that was part of the issue. The other part of the issue was that it was not clear to those in the FDA and maybe even those in Congress how those delays and swapping of your lead reviewer multiple times were impacting companies. And so what we tied together was the delay. We actually showed how long it takes and how long it has changed, tied that to actual dollars, because what people don't realize is, you wait a year, that's a year's worth of salary and years worth of expenses for all those key experts and people that need to be in the company for them to be a legitimate, healthcare company. One extra year, and who pays for that? Well, it's the venture guys that are paying for it, of course, or it's the companies that are paying for it. But ultimately, it's the patients and the healthcare system that's paying for it. So these are unnecessary costs and delays that, if optimized, could really minimize costs. And really, the main theme was that, is it really improving safety, or is safety an issue? Actually, the performance of FDA is outstanding. So these changes don't need to be made on a safety basis. They were just being made because of a mindset change that was not based on actual data.
And I think one of the important things that you brought out in that report and in subsequent reports is, in addition to patient safety, improved outcomes, there's the element of investment in the industry as a whole, and the notion of, look, these investors have other options as far as where they can put their money. And so if we're looking for investors to back medtech companies, these are important issues that need to be addressed from that perspective as well.
Right. Exactly. And I think, anyway, those are, we could take those program.
Yeah, no, that's fine.
I don't want to do that. I'm sure you don't want to do that, but not enough to say that we painted that picture in full detail with a fair amount of data from over 200 companies, brought that forward, and it was a very useful instrument. Interestingly, after we did that, that same similar kind of work in pieces was repeated by multiple independent parties, and maybe even independently verified, at least the piece that they could verify at the FDA. So I think we all wound up aligning around, this is the facts, and those were all brought to Congress by us and others, and resulted in changes that were introduced into the user fee negotiation that was ultimately signed into law, which is the Food and Drug Administration Safety and Innovation Act that Obama signed into law. And since that time, that was in 2012, it was signed into law. And since that time, we have seen real change. And I would say, in terms of the things that concern innovators the most, FDA is not the number one issue that is delaying access for patients to medical technology innovations. It is actually reimbursement and payment, and that whole system in the United States, that is really where all the delays and inefficiencies are today. So that congratulations to all the people at FDA who contributed to that, and also industry for, I mean, there were things that industry needed to do too, and I see that they've sort of come together in pursuit of trying to bring better technologies for patients.
That's a great segue to bring us up to kind of the current day, and I should also add that, and I think there's certain kind of been a perfect storm here, where with the challenges and complexities of MDR, the new medical device regulation in Europe, combined with the switch that we just talked about occurring at FDA, what we're seeing now is, instead of companies going to Europe first, now more and more companies are really looking to go to the US first to begin commercializing here before going to Europe. But so segue to the current day, and I think it's fair to say, as you just mentioned, that reimbursement has replaced regulatory as the number one issue facing medtech companies. And it's interesting. I mean, not that many years ago, when I was out talking to CEOs to do articles, and if you brought up reimbursement, they often would say, well, I'm not really worried about reimbursement. That's something that when I get acquired, the large strategics will take care of that. I don't have to worry about it. Whereas now, I would say, not only do potential acquirers want to see at least a reimbursement plan in place, but even investors want to see that as a box that companies are considering and have put a strategy in place. So let's kind of lead into the report that you did last year, just as a highlight, and then we can segue to the current report. And this was the first, I think I'm right, that this was the first report coming out of the policy program. And for those who aren't familiar, when Josh took over the Stanford Biodesign program after Paul Yock's retirement, one of the things that you implemented was to add a policy fellowship and a policy program to the biodesign. And the first product of that was a survey that found multi-year delays in access to breakthrough medical devices. So why don't you take a minute to kind of summarize that, and then we'll lead into the current report.
Absolutely. Again, when we had the notion that we're going to put together a policy program, in advance of anything being established, the real question, I think, for any donor or anyone being involved is, does Stanford Biodesign have anything to do with policy? And, the idea that we would get a policy program together was a notion that needed to be vetted and supported and so on. So immediately, within a month of starting, Sandy Ruggles and I here, Sandy's a former fellow grad and a leader here in the biodesign program, kind of put together this idea. Let's just put a stake in the ground and show that we can actually do something in policy as we're getting all this policy program together. So I'd say some of this work really initiated before the formal policy program was underway. It has now formally gotten underway with the joining of Kavita Patel on July 1st. She became professor and director of the policy program here officially July 1st of this year. And we welcomed our first fellows in the program in August of this year. It is officially. So these are some of the, let's say, the preamble to the policy program activities. But we said, all right, what can we do? And I spoke to numerous stakeholders, and it really, again, arose that reimbursement payment is the biggest issue. And we also saw that there was a recent rule that had been, that was likely to be canceled. We believed it might. I don't know if it was canceled yet, but this rule called MCIT, Medicare coverage for innovative technologies, had been put forward and was at threat of being canceled. And we thought this is something that could actually really help innovation and be a model for even private insurers potentially. So we thought that based on all the feedback, that would be an area to focus. And really the first objective of the first paper that we published in January of 2022
Right.
Was an illustration of what's going on in the innovator community around reimbursement today, and also what are their thoughts about this MCIT proposal, and how might it be modified or changed to be even more successful or address some of what we already knew or some of the concerns about it from.
You want to take a minute and just I never want to assume that people are familiar with all the acronyms we throw around. Just want to outline what MCIT provided for, even though obviously it never took place.
Yeah, in broad strokes, it was if you had been designated to be a breakthrough by FDA, that you'd be guaranteed accelerated or let's say transitional coverage for at least 4 years, I think it was, post your FDA approval. And during that time, you got coverage. So you sort of granted coverage during that time, and then there'd be an evaluation period by CMS afterwards to see if you still deserve that coverage after more data is available. And that was sort of at the high level, that was the idea, and applied to all breakthrough technologies as designated by the FDA. And that was canceled ultimately by CMS, but they sort of said, we'll come up with something else that they'll propose in its place. And today we know that is the TCET proposal. And finally, within the last 2 months, we've actually gotten a look at what that is. And that's where we're at today. But back to that first paper, the real goal was to paint what are the perspectives of innovators with respect to MCIT. What are the ways we can solve some of the problems that have been addressed by MCIT, and how important is it for industry and investors in the innovation ecosystem that something like that exists. And that's pretty much what that paper was.
Hey, have you heard of Market Pathways? Market Pathways provides the most in-depth analysis you'll find of the changes happening in medical device regulation and reimbursement every day. They address the complexity in regulatory affairs and beyond by helping you digest and contextualize technical topics like Medicare and MDR. Visit mystrategist.com/trial today to start your free 5-day trial to Market Pathways. Again, that's mystrategist.com/trial for 5 days of online access.
Everyone, I'm Joey Brenneman from Offscript Health, and we are excited to introduce you to Offscript Health's latest podcast series called Before We Die, the world's best podcast about the med tech industry. Every day, advances in technology are providing new, less invasive options in healthcare. Many of them are born out of the idea that there has to be a better way. On this show, we will be talking with the rock star innovators and inventors of the medtech industry who felt the same way, which inspired them to create a new device or challenge a way that a procedure was done. And most people don't even know who they are. So download and subscribe to Before We Die, wherever you get your podcasts. You'll get full episodes every Tuesday, and on Thursdays, you'll get our Lab Before Slab mini episodes where Sandy, John, and Craig geek out about the latest happenings in the medtech world. Who would have thought that medical innovation could be so riveting?
And in terms of the approach or methodology you took, I think it's important to understand that you built on what Congresswoman Eshu's advice was to you: bring me the data.
Right.
And that's what guided you in the first report.
Yes.
And that guided you in the second report. And the reason I think that's important is because I think it's fair to say, and I'm not taking political sides here, but that the attitude has changed generally in society and government with regard to data. And what was once a given, and that is the understanding that scientific data collected through generally accepted principles would not be questioned. I think that is different than what we're going through now. And I'd be curious, and again, Kavita Patel came out of the DC environment, so she knows that better than anyone. How, if if at all, do you structure the report going back to 22, and then we can talk about this year, or do you just say, look, we're going to do it the way we've always done it, which is we're going to produce the data, and whatever the data shows, that's what we're going to publish in the report? But in other words, how has the current environment affected your approach to these reports, if it has at all?
Well, it certainly has at one level, but the good news, at least still in this domain, is that there is a fair amount of bipartisan support for improving people's health, advancing innovation. As you get into some of the nuances underneath what is forming that alliance, it's slightly different between the two different parties, but you don't need to touch those third rails to actually elevate the discussion. And whether you are trying to protect, U.S. industry, or whether you're trying to protect patient safety as a primary goal and sort of outcomes, so it doesn't matter. Those sort of come together with a unified set of messages that we can all align on. And so, yes, the goal was to use data again. And I'd say that is going to be a theme that you will see for our policy program going forward. Not that we wouldn't put out opinion pieces, and we do intend to do that. That is, we're not going to not have an opinion, but so we will put out some opinion pieces in the future as we sort of amp up our abilities to do that. But we will also amp up our abilities to do more data. And part of that will be in collaboration with the fellows, but we'll also have broader relationships across campus to kind of bring some more data there. So this is that 22 report was really about sharing the data on the perspectives and opinions. And then we just released a new article in JAMA Health Forum, which really shows quantitatively, based on publicly available resources, the timeline to a nominal amount of coverage for new novel medical technologies that really are in need of new coverage frameworks, and how long it takes, and really shockingly, how many, even many years later, still do not have even the most nominal level of coverage. And I think it's pretty devastating and concerning. And so that's the latest data set, all along the same general theme.
So I want to delve a little bit into the most recent report. Do you want to talk a little bit in detail about the data set used, the number of companies, the time period is involved?
Yeah, I'm gonna. So there's and I would refer anyone to the free article online, JAMA Health Forum, on that we published in the first week of August, for more information on this. And also we have we had a webinar last week, and that is also going to be publicly available if people want to see a discussion about this and presentation of the data in a little bit more detail.
And I also want to interject, we'll also follow up with an article in Market Pathways to just continue to help try to get the information out to people.
Great, thank you. The summary is, there is a median of 5.7 years between FDA approval for a novel medical technology and coverage, historically and we looked at a cohort between 2016 and 2019 and followed them forward to the end of 22. And only 44%, and this is about 64 technologies, wound up in the bucket. There are many more that were approved by the FDA and many more that were novel, but those that already had a coverage framework were excluded, and there were a couple of other exclusions. And again, the endpoint that we're considering an endpoint, which many in the industry including myself, would they say that that nominal Medicare coverage of like 3 LCDs that are positive is really nothing, but we had to put a stake down somewhere, and that seemed to be a reasonable minimal stake to actually have a company that can survive at some level in business. And that therefore we put that stake down, but that is, I think, debatable. But anyway, to that same level of novel coverage, the median 5.7 years, with many, some as long as 7 years. And obviously in the survey, some had never achieved it. In fact, most had not achieved it during the period of time. So it does shine a light on this issue, and gives some real data for people to chew on, even if you have had an alternative view of the whole scenario. I think it's worth paying attention to. It's a real concern for innovators and also for patients.
The other thing I thought was interesting, and there are a number of interesting points, but in terms of general themes,
they say that that nominal Medicare coverage of like 3 LCDs that are positive is really nothing, but we had to put a stake down somewhere, and that seemed to be a reasonable minimal stake to actually.
I also want to interject. We'll also follow up with an article in Market Pathways to just continue to help try to get the information out to people.
Great, thank you. The summary is there is a median of 5.7 years between FDA approval for a novel medical technology and coverage, historically and we looked at a cohort between 2016 and 2019 and followed them forward to the end of 22. And only 44%, and this is about 64 technologies wound up in the bucket. There are many more that were approved by the FDA and many more that were novel, but those that already had a coverage framework were excluded, and there were a couple of other exclusions. And again, the endpoint that we're considering an endpoint, which many in the industry, including myself, would they say that that nominal Medicare coverage of like 3 LCDs that are positive is really nothing, but we had to put a stake down somewhere, and that seemed to be a reasonable minimal stake to actually have a company that can survive at some level in business. And that therefore we put that stake down, but that is, I think, debatable. But anyway, to that same level of novel coverage, the median 5.7 years, with many, some as long as 7 years. And obviously in the survey, some had never achieved it. In fact, most had not achieved it during the period of time. So it does shine a light on this issue, and gives some real data for people to chew on, even if you have had an alternative view of the whole scenario. I think it's worth paying attention to. It's a real concern for innovators and also for patients.
The other thing I thought was interesting, and there are a number of interesting points, but in terms of general themes, was that time to coverage also seemed to vary by product type,
yeah,
to a certain extent, and also by size of company. And
right.
The reason I think, and again, this is stating the obvious, but the reason that's particularly important is because we know in medtech, the sources of innovation are, no disrespect to large strategics, but sources of innovation are small venture-backed startups.
Right.
So if those companies are the ones that are disproportionately impacted by not being able to get reimbursement, what we're doing, again, going back to the theme we've talked about here before, which is you're threatening the innovation pipeline. So kind of address those 2 points. Why do you think the impact seems to be larger on smaller companies rather than larger, and also on different types of products? I thought that was interesting.
Yeah. Yeah. So the two interesting insights were, like you said, that bigger companies had shorter timelines. And you can attribute that to probably a few factors, but we didn't study these in detail. So I'm going to say my comments right now are based on my inklings from the data, but are not based on some rigorous methodology that would have produced this insight. Otherwise, we would have tried to do it. It's just a little hard to do. Like, what's a lower risk project versus a higher risk project? You know? But you might say that bigger companies, they're more resourced with more experts around, so they've got every ability to never or reduce the likelihood of mistakes or inefficiencies. They've got more time invested in sort of building the relationships and all of that, where small companies are sort of coming at it a little bit fresh and sort of under-resourced. And then also the types of projects that they take on generally fall within sort of known categories in general. So they may be not too far elite, maybe not be too disruptive. They're just sort of adding on to known knowledge and therefore don't necessarily provoke as many new questions and therefore are more likely to navigate the process faster. I mean, as a society, as patients suffering, we want to see big leaps, and so that's why it's great that small companies are willing to make those really radically big leaps. And not that big companies don't do those, but they don't do them as frequently. And I think we probably get alignment on that. So you're seeing some of that in the data. The other thing you're seeing is, because I think that there would have been a criticism that, I mean, the reason why it's taking so long is they don't have high quality data. And so if you don't have high quality data, of course it's going to take longer. And the interesting thing is that there actually is no difference whether you have a level 1 evidence or you don't. And if you have level 1 evidence, that means it's a randomized controlled, pivotal study. And even those studies that did have randomized controlled data performed equally as poorly as those that did not. So it's not that as a factor. Now, you could say on top of that, well, what was the percentage of seniors in these populations or so on? And that could be a reasonable further add-on to what the delays could be associated with. So that's possible. Again, we did not have the next level of analysis done. Could be something that we look at next, but certainly, what level of senior, participation, and then again, even if we measured that, is that adequate? Would be another question that we also didn't answer. And some of these issues come from a little bit of a lack of clear definition about what reasonable and necessary is, what that standard really is, and how I think that how is that defined for various stakeholders is a little bit fuzzy. And it's clear when FDA lays down a pivotal study, it's clear what the safety and efficacy thresholds are. That's clearly laid out in the protocol, clear from the beginning. And when you don't hit it as a manufacturer, you haven't. It's not as clear what hits a reasonable and necessary standard for manufacturers so that they can design studies to properly hit that. So that is still a challenge for us.
So that's a great segue into what I'd like to focus on during the last part of our conversation, which is talking about the TCET proposal that just came out. But let me frame it in terms of, if you look at the 2010 report, it really was the scaffold, if you will, for significant progress that we've already discussed that has taken place at FDA. Is it unfair to expect the kind of data that you're generating from the studies that you did last year, this study, and perhaps studies to come, that we can expect that kind of progress to occur at CMS? And then I want also to touch on the whole issue of resources, because clearly a big part of the progress at FDA is the increase in resources that the agency has seen over the past decade. It's no secret, and the last thing I'm trying to do is trash CMS, but it's no secret that CMS has long been under-resourced.
Right.
And so the question is, can progress be made without additional resources? Do the two go hand in hand? I mean, one of the interesting points, I thought it was a small point, but came out of your most recent report, was how rarely kind of joint programs like parallel review and CED really were used. There's a very small number of cases where you have the two agencies kind of working together. So what are your expectations of how this kind of data can be used to perhaps bring about the same kind of changes at CMS that we've seen at FDA?
Yeah. I think that similar to the changes that we ultimately saw happen at FDA, that it didn't happen without some degree of congressional oversight, involvement, whether it's mandate or direction. So I would not be surprised that it takes that to either create the resources available or to create the prioritization that it may deserve. I think those are some things. I do think similarly to those days that just like we had with FDA, everyone in the agency wants to do the right thing for patients. And they are working within the parameters and, sort of leadership that they've been directed towards. And so there's no impugning of anyone's motivations here. It's just what can you do within the parameters that you have available to you. And to the extent that we, as external to these agencies, can play a role as citizens of the United States, as patients here in the United States, to present facts, to present opinions, and advocate for improvements. That's what our job is, and hopefully those messages are listened to, both within the agencies, but also in Congress and the White House, and they actually result in a real change that benefits everyone and has us working better together to improve and advance patient care.
So it sounds like, and I'm not trying to put a conclusion in your mouth, but it sounds like you're of the view, as are, I think, many, that really the proposal that came out in June really falls short, and that it's likely that we're going to need some kind of congressional action. But let's spend a couple minutes just talking about that proposal, because I'd be interested to get your perspective on it. We just did an article in Market Pathways. I did it with my colleague Dave Fillmore in our current issue, talking about the proposal. And I think, just to summarize it, I think it's fair to say that instead of establishing a new coverage pathway in the TCET plan, CMS really stayed within the bounds of the current national coverage determination, the NCD, CED framework, proposing to kind of front load the NCD application process for selected, and I think that's key, select breakthrough devices. So it's not automatic for every breakthrough device, to accelerate data review and generate what they call fit for purpose evidence development plans prior to FDA authorization, with the goal of issuing final coverage policy within 6 months. And I, again, emphasize that's a goal because, again, going back to the whole issue of CMS having limited resources. And so in talking to some folks, leaders in the industry, I just want to read you a couple of quotes and see what your perspective is. So Nadeem Yared, who's president and CEO of CVRX, and has been a leader with several medtech organizations over the years, said the proposed TCET is a significant improvement over the current NCD with CED pathway, but may only improve marginally the investment case for innovative new devices, as the coverage is not automatic. Going back to the point we made about the impact this has on investment in addition to patient safety and outcomes. And then Mark Leahy, from who we've talked about before from MDMA, said that while the proposal includes positive features, in order to truly maximize the potential of this amazing industry to alleviate suffering and save lives, a broad, robust pathway separate from CED needs to be in place. Would you agree? Would you agree with that?
I do agree with both those comments personally. I think that this proposal does offer some improvements upon the existing CED pathway, but it does not accomplish the goals or vision that was a part of the MCIT proposal, which was flawed in several ways, lacking clinical data, evidence generation commitment, et cetera. But this happens way too late on way too small a number of technologies, and it is not going to inspire the advancement of innovation in new therapies. And I think it's, and there are other aspects of the frameworks that still exist for CED and CD that scare, and even parallel review for that matter, that scare away most manufacturers, and those have not been addressed. In fact, in some cases, there are some new features of the TCET proposal that are a little bit more scary for manufacturers. So I worry that, it's going to have a very small impact. And it is, I think it could be so much more. I guess my expectations were that it could really be modified to be so much more, or ideally, like Mark said, a new pathway could really be defined that does not have all the limitations and constraints that the other one does. And the resource allocation is, of course, relevant as well.
Yeah, I want to wrap up on that point because I also want to highlight a recent AdvaMed report that came out that also emphasized, among other things, the need for additional resources at CMS. And I guess I always like to try to close on a positive note, but it sounds to me, from what you're saying, from looking at the AdvaMed report, that really whatever may happen, either administratively or legislatively, that the reality is that without additional resources for CMS, it's unlikely that we're going to see the kind of anywhere close to the kind of change that we saw over the last decade at FDA. Would you agree with that?
Basically, I would, with the caveat that, as I've spoken to various people, even former CMS officials who are no longer with the agency, that the resources to support this do not necessarily need to incrementally add on top of the existing CMS allocation of resources, and that this could be a reprioritization within the agency rather than just having to increase the overall total funding of it. So I don't have the experience or insight into the details of how that is done, but that counter view has been shared with me, which I think is relevant as we think about resources. It's also about resource prioritization and how valuable do we think innovation is and advancing new therapy is for overall cost savings and elongation of the lifetime of Medicare services, et cetera. If you fall in the camp where I think I do personally, which is that many of these technologies are designed to be cost effective and therefore would improve the cost effectiveness of therapies, even though they would seem to be, let's say, more expensive up front, but maybe in the long run, since these are beneficiaries until death with Medicare, they could save money for Medicare if we just manage some of these diseases better. That's sort of a view, right? So that is my view. Can it be proven for various technologies? How is that prioritized? But anyway, so there is so I would just defer and say that there more resources are necessary to be applied to these programs to make them successful. Totally agree. Where those come from Does it really require an increase in allocation, or is it just a shifting of internal prioritization? That's a TBD.
Well, that at least I think lets us end on a glass half full note. So I think that's and it's also, again, in an age when budget battles in Washington make it difficult to provide increased funding, the notion of reprioritizing the funding is an interesting notion. So with that, Josh, thanks so much for this discussion. I know that we're going to be circling back, and this is not the last time that we're going to be broaching this issue on reimbursement. So we really appreciate all the good work that you and the Biodesign program are doing on this.
Thank you so much. Thanks, Steve. Great to chat with you.
We hope you enjoyed today's discussion with Josh Makower. We tried to keep the acronyms on the light side and hope we didn't get too acronym heavy. And we know that this is going to be a discussion that will continue, and I'm sure will be the topic of future podcasts as well as future articles in Market Pathways. So we encourage you to follow us both in the publication and on the podcast to stay abreast of what's going to happen with the whole TCET policy. Thanks again for listening.
We hope you enjoyed that episode. Your support is valuable and makes us better. Please remember to leave a review and rate Market Pathways on Apple Podcasts or wherever you happen to listen.